All right. Well, good morning, everyone. I'm Anna Ogina. I'm a pediatric hospitalist and your AAP Alaska chapter president. Welcome to our pediatric grand rounds today, Tuesday, May 2nd, 2023. Today's topic is The Only Lane is Safety, Pediatric Gun Violence in the U.S. and Why Healthcare Providers Must Address It, by Dr. NIcole Webb. But before I introduce our esteemed speaker, I would like to recognize that this Zoom Grand Rounds is hosted in Anchorage, Alaska, which is the Dena'ina et Nena homeland. This land acknowledgement is to show appreciation for the past and present Indigenous stewardship of the lands where we now live, work, and play. Some housekeeping items, please mute your microphones during the presentation, but we do encourage you to turn on your camera video so that we can see each other from wherever you are zooming in from across the state and elsewhere. This Pediatric Grand Rounds will be recorded for educational purposes and archived on our aapalaska.com website. You are consenting to this recording by attending. Please do participate and ask your questions, share your experiences in the chat box. You can also unmute yourself during the Q&A portion at the end. You will be able to claim CME for viewing and attending in real time only. A link will be provided in the chat box so you can fill out the brief form and print your CME certificate immediately. So with that, I'd like to introduce our speaker today. I'm really honored and excited that she's here. Dr. NIcole Webb is an associate professor of pediatrics affiliated at Stanford University and a pediatric hospitalist at Valley Children's Healthcare, where she serves as the founding program director of their Pediatric Hospital Medicine Fellowship, as well as the chair of the Education Committee and the GME Subcommittee on Diversity, Equity, and Inclusion. Regionally, she is the rising president of AAP California Chapter 1 and serves on the executive board of AAP California. Nationally, she serves multiple leadership roles within both the AAP and the Society of Hospital Medicine. Dr. Webb is a longtime pediatric gun violence prevention advocate and a nationally recognized speaker on this topic. She is the founding member of Moms Demand Action Fresno and was an inaugural member of Moms Demand Action Healthcare Providers Affinity Group. She is deeply committed to working with community partners to promote evidence-based, equitable, collaborative solutions to preventing gun violence in children and adults. It's an honor and privilege to have you here today, especially after coming back from PAS. And that was in DC, wasn't it? So with that, please take it away, Dr. Webb.
Thank you, Dr. Ogina. It is an honor to be here virtually as well. And I will share my screen in just a minute. I just wanted to be able to actually see the Zoom screen for a moment. Dr. Ogina and I have gotten to know each other through our shared work in the AAP, and she heard a very similar version of this talk at the Society of Hospital Medicine. I've lost track of time, I think a little over a month ago. And asked me to join you all here today. So some of the content you will see kind of pertains to hospitalists, which is the work she and I do, obviously, but it's really more broadly applicable. And if I'm being totally honest, I kind of put a lot of that in because of the ask of that original talk, but also because I think historically in our field of inpatient medicine, this has felt like not a thing that we address. And I think that there is really an imperative to change that and for all of us to be discussing this, which I imagine many of you probably understand. Also just wanted to say on a personal note, I realize demographically California, where I practice, and Alaska probably couldn't be very much different. I grew up in northern New England, in Maine specifically, and so while that is still a lot less remote in many ways than many parts of Alaska, I'm very familiar with having a higher probability of running into a moose than running into a famous person, and really with a lot of the kind of cultural reasons why firearm ownership is relevant in ways that might be different than a lot of us in urban centers, often kind of the examples that we gravitate toward. And one of the things that I think is really important in this work is that folks bring a little bit of their own personal story to their advocacy and understand the context in which firearms are playing a role in homes and communities, because taking kind of a one size fits all, very sort of scientific, just the facts approach is often not compelling. And so I do want to recognize where you all are is quite different than where I am now, but a little bit of familiarity with that and hunting and kind of needing to live off the land was very much a part of my childhood, even if it's not part of my day-to-day as much now. Okay, so let's see if this is gonna, we know it's gonna work. We just did that. I'll put it in slideshow mode. Okay, so moving right along, I don't have any financial disclosures. As Anna mentioned, I do work both with Moms Demand Action and then a lot of work within the American Academy of Pediatrics. And probably in this context, neither of those are especially like earth-shattering disclosures, but depending on who I'm talking to about this, I always try to be forthcoming about that. Overall goals are really just to apply a framework of safety and harm reduction when discussing gun violence and gun violence prevention, and then to learn, or I'm suspecting probably many of you already know a lot of this, build upon evidence-based strategies for how we can address this at the clinician or individual and at the systemic level. And it's a small enough group. If I can go through these quickly, hopefully there's like room for more discussion. So just in terms of specific objectives, understanding epidemiology is really important, and particularly understanding racial and ethnic disparities in pediatric firearm mortality. Understanding the role of guns in suicide is not talked about enough, and so I will spend actually quite a lot of time on that today. And then kind of related to all of this is understanding the role for screening for access and then providing counseling and resources for secure storage. And I hopefully will convince you that that's an effective means actually reducing all intent types of pediatric gun violence, not just the unintentional injuries. And then just a little bit about words matter. And I am for the one of you who knows me, I'm often a sarcastic person. And so in a friend context, sometimes maybe not as thoughtful about words as I could be, but in this context, we want to be sure that the words we use to have these conversations don't unintentionally kind of shut down the conversation before it starts. So here's a couple examples. So gun control is a very polarizing term. It, you know, again, when I've done this talk before, imagine if someone told you they wanted to control you. Like, how does that already make you feel before any other conversation has happened? Accident and tragedy are a little different, and I have a typo on my slide that I'm just now noticing, which is going to drive me insane. Anyway, tragedy are a little different, and the reason is that there's this sense of inevitability with those words. When we talk about accidental deaths, it's like, oh my God, what a terrible tragedy. It's so horrible. And we focus on the aftermath and what happened. And obviously, you know, these events rip apart communities, but there's this sense of like futility. And what we really want to focus on is these are preventable. So rather than when we describe specifically and talking about epidemiology and data, rather than saying accidental shootings, we try to talk about unintentional shootings because they could have been prevented. So they're not, you know, really accidents in the way that we often think about them. Again, and tragedy it has this inevitability kind of associated with it. So I'm not suggesting we would correct someone in the moment when they're kind of sharing grief. But as we think about news headlines and when we give presentations, when we kind of discuss data, trying to focus on words that are more precise. And then this is just I'm clicking through this quickly. What I really wanted to show everyone, you'll see a lot of AAP in there, American College of Surgeons. Virtually every major medical society, and not just physician provider groups, but nursing groups and interprofessionals has come out with statements recognizing anywhere from just sort of recognizing gun violence as a public health epidemic in this country, which is what our Anna and I are both members of Society of Hospital Medicine really finally did last summer. I would say very long overdue. Going back to a lot of societies like American College of Surgeons and the American Academy of Pediatrics that have been saying and kind of sounding the call for many years about this, and not just sort of putting out press releases, but really kind of trying to offer resources and trying to take an evidence-based public health approach. So this is not, but this has really moved into the mainstream of medicine in the sense that these societies now are not so afraid of kind of being the vanguard if they make a statement, because everyone is talking about this, as we should be. I was just at PAS, as Dr. Gina mentioned, over the weekend, and there were multiple talks on this, which is the first I've ever seen at that meeting. This is really heartening to see, and everybody had some version of this infographic because this is really striking. So the United States has, I mean, you can see the graph there. It's a picture's worth 1,000 words, right? By far and away the highest child and teen firearm mortality rate among peer countries. And in fact, when teens globally in high income countries, of teens within the age group depicted here who die as a result of guns, over 90% of those teens globally are dying within the States. So just to say that a different way, this is really uniquely an American problem. While guns themselves are not uniquely an American concept, certainly I think they're very embedded into our culture here, but there are other countries, including our peers to the north in Canada, is a great example that have comparable rates of gun ownership, but yet don't see the same and not anything close to the same incidence in for firearm mortality. Every time I do a talk, I have some generic slide talking about mass shootings, and then a mass shooting happens. And so I substitute that. So this is actually now several days old, but as I was at PAS getting ready for my own poster session, which was not on this topic, the news was breaking about a mass shooting in Texas where some neighbors asked their next door neighbor to stop shooting in his backyard. He had a semi-automatic weapon. He was shooting after dark. They had a baby they were trying to put to sleep, and he responded by shooting everyone there. 5 people, including a child, died. This is just one example of so very many. At the end of this talk, there's a QR code. There's a lot of QR codes throughout the talk. I want to kind of clue people into high yield papers and resources if you'd like to click those in real time. But at the very end, there's a repository with absolutely every single resource that I talk about here, including if you're interested in learning more about mass shootings, how we define those and how they're tracked, resources to that as well. But I did want to say this isn't a mass shooting talk. Because really the majority of gun violence in our country is not occurring in the context of mass shootings. And even when we talk about mass shootings, the majority is not occurring in schools or churches or movie theaters, although it does increasingly feel like there are no safe spaces in this country. The majority of gun violence, whether it's a mass shooting or an individual shooting, is occurring in homes and communities, and that's just all that's meant to be depicted here by that picture of some houses. And it is worth noting the most commonly accepted definition of a mass shooting is 4 victims, not including the shooter. And the vast majority of those are actually not these big public ones that make the news cycle. They're things much more like that New York Times headline that I just shared. And they're very, very often, that one was not, but they're very often in the context of domestic violence disputes. And so I think when we think about even the homicide category, which we'll get into later, it's important to be thoughtful about that. But I did also want to point out that while the school mass shooting in particular is rare, it certainly garners headlines, it garners all of our emotions. I know as a parent, I still have this hesitation when I send my kids to school. The statistical likelihood of them dying in that manner is very low. But 75% of American high school students report this as a major source of stress for them. So, when we talk about gun violence, we're often so focused on mortality because there's really, it's such a chilling statement when we put up graphs like the one I just showed you about how this is, we're number 1 in the world for this. But if you really stop and you think about not just mortality, but injuries, and then the way communities are torn apart, or just living daily with the fear of what, my sister, who's younger than me, referred to her childhood as generation lockdown. That's it's the scope is really astronomical, and so there's not a lot of time today to cover that. But I think it's very important to acknowledge that our children are growing up in fear, whether they ever see a gun or hear gunfire. I'm going to skip over my kind of story here in the interest of time, but my personal career in pediatrics is really bracketed by these 2 very high profile mass school shootings. And again, epidemiologically, this is not how most people die, but I think these are often the things that get us to the table. And so the Sandy Hook elementary shooting in Newtown, Connecticut happened just a few months into my first faculty position, and I was pregnant with my first child. And then Uvalde happened obviously last summer, and I was actually at home quarantining because I had tested positive for COVID, and spent a lot of time reflecting on what had changed. That entire decade in between, I've been involved in gun violence prevention advocacy, and really a lot has in terms of advocacy. But yet at the same time, this has gone from the 3rd leading cause of death of American children back in 2012 to now the number 1. And that was a sobering moment for me, and just sort of a reminder to continue this work and to look for new avenues for collaboration and dissemination. Okay, so a little bit of an overview of the kind of breakdown here. I'm going to talk about epidemiology and then we'll get into some of these other topics. I'm not going to spend a lot of time on this, but for anyone who does research either currently or in the past, you probably are aware, as I certainly am, that where the money is where the research gets done and where the publications come. So in the top left, you see research funding, and in the bottom, you see publications. And what hopefully is noteworthy, this is for the most common causes of death, all ages, so including adults in the United States. It's a few years old now. So it predates COVID, where we know gun sales skyrocketed and gun injuries and mortalities have as well, both in adults and children. But what you can see is that gray bar is like the sweet spot where sort of funding kind of matches disease burden in the population. And then way at the bottom, only slightly above, falls and incidentally drowning, which both affect children a lot as well, is gun violence. And again, similar pattern for publications. So if there's not funding, there's not going to be research. If there's not research, then there's certainly not going to be publications. And then this obviously becomes a huge problem when we talk about trying to know what we need to know to address this. And I really do think it's actually what's held healthcare back tremendously, particularly in the last decade, where we've seen a lot of these grassroots gun violence advocacy groups doing amazing work and not saying, okay, we don't have enough data, so what can we do? And to be completely honest, is a huge part of why I personally not left the healthcare space in terms of my practice, but left the healthcare space in terms of my advocacy work for a number of years and got involved with Moms Demand Action specifically, because they were doing amazing work and not letting the absence of data be a barrier to that. In fact, Every Time for Gun Safety has been a major driver of gun violence research in this country for the better part of the last decade. So why are we here? And I can't see your hands, but mentally raise your hand if you've ever counseled a patient or parent about any of these issues. So bike or pedestrian safety, falls, which you just saw, are not funded enough on that previous slide. Water safety, also not funded enough. Ingestions or poisoning, suffocation, or car seat or vehicle safety. So hopefully everyone's figured out by now that these are the major injury-related causes of pediatric death in the United States. So the numbers specifically refer to pediatric deaths in the year 2020, which is the last year for which there is a complete data set available from CDC, which is the source of this data. And then just to kind of continue that, but with some of the diagnoses, some of us, especially Anna and I, may be more familiar with treating. What about bronchiolitis, meningitis, diabetes, sepsis, flu, cancer? Yeah, so those numbers actually, first of all, I think it's noteworthy that they're considerably lower than most of those injury-related numbers. So preventable things are what kill American children. We've done actually very well with therapeutics for treatable disease, and there's always room for improvement. And pediatric cancer is woefully underfunded compared to adult cancer, but still astronomically more funded than really any of the injury-related causes of mortality in pediatrics. And so as though that's not sobering enough, this is how many children were killed in the United States as a result of firearms in 2020. And hopefully everyone can see that that number is much higher than the next highest number, which was motor vehicle collision. And so this is something, you know, we're healthcare providers. We're here to promote the optimal health and well-being of children, specifically within the American Academy of Pediatrics. And so this is our lane. And again, referring back to the title of my talk, it's not just our lane. This is the only lane. This is the only lane anyone should be talking about this in the context of, like, if you leave today with nothing else, like, it's hopefully a sense that this is absolutely your job to talk about. It's absolutely your right to talk about it. And the way you should talk about it should be focused on safety and not politics. And I know that can be hard and overwhelming, but that's the only lane. It's the only reason we care, or that we should care. So as I said, I had given this talk to some hospitalists, so I was just including the fact that unlike the broader American Academy of Pediatrics, which had been talking about this for quite a while, and sort of the pediatric space in hospital medicine, we had not, and that's changed a lot recently. So this was an editorial very recently in the Journal of Hospital Medicine by several of my friends and colleagues who are nationally renowned gun violence prevention advocates as well. That's just kind of been pointing to that there. And then we're a decent number of slides in and getting to kind of the major point here, which is, as I've already kind of alluded to, guns have overtaken motor vehicle collisions as the #1 cause of death of American children. If you look at this figure here, Goldstick and Al published this. It was actually a commentary in the New England Journal of Medicine in 2022 in response to earlier work they had done looking at major causes of death in children and really acknowledging this shocking trend. So motor vehicle collisions had long been the #1 cause of death of US children, which is already like really hard for me to sort of swallow as something that's preventable. But what you see in this huge, drop in the 2000s is that was a period of tremendous change in child passenger safety advocacy in the United States. And so recognizing a public health problem and taking a public health advocacy approach, which had very much a legislative policy component. In fact, the legislative policy change was the driver of this drop in mortality. We saw tremendous improvements in the robustness and number and sort of standardization of child passenger safety laws and requirements around not just how the state is secured in the vehicle, but like tremendous improvements in the quality of the restraint devices being produced during that period of time. And so we've certainly not gotten that number to 0, but it's dropped tremendously. And then, think of what we've done in the realm of, and we, I mean, as an American culture, not we, healthcare, to take a similar approach to guns. And I think we can all agree it's basically non-existent. And then there's this inflection point. The main thing I want everyone to notice is that inflection point where guns have now overtaken cars as the #1 cause of death of US children. That's before the COVID pandemic. And what we do know is gun sales skyrocketed, gun injuries skyrocketed. And as that data starts to come out, it's even worse than many of us anticipated that it would be. So I think when we look at this same graph in a couple of years' time, with a look back window of the 2020 to 2023 era, we're going to be having even more sobering conversations. And one of the things that's really challenging in public health advocacy work is you're advocating for change based on data that's already 2 or 3 years old, kind of having sense of where things are going. And so this is why other groups doing this work and collecting this data and other means to give us more real-time information is really helpful. So I'm sorry for the colors here when I kind of merged these from a different template. They got all kind of hard to read. But again, I mentioned earlier that, gun violence isn't just about who dies, it's much bigger than that. So for every child who's shot and killed, another 4 or 5 are shot and injured, and 3 million children are exposed to gunfire in this country every year in the United States. Children 5 to 14 are 21 times more likely, and children 14 to 24 are 23 times more likely to be killed with guns than children in other high-income countries. And I mentioned this earlier, but I want to kind of really draw attention to the link between domestic violence or interpersonal violence and pediatric gun violence. So 85% of US child homicide victims less than 13 die in the home. I'm going to say that again. 85% of US child homicide victims less than 13 die in the home. And you can see that statistic there about between the time period of 2009 to 2020, how many children who were victims of mass shootings were actually dying in domestic violence incidents. This is not talked about enough. I had the good fortune when I was in Washington, D.C. for PAS last week to attend some meetings on the Hill with a colleague, Dr. Kelsey Gastineau, who had organized some Hill visits in response to the Covenant shooting in Nashville. And we didn't have any meetings with legislators in California, so I joined the Tennessee cohort, and we were meeting with Senator Blackburn's staffers. And they were asking us about data, and they were, specifically kind of went to that place that people often do of bringing up homicide, and they started asking about gang violence, and that is very important to address, and understanding the drivers at a sort of granular level of gun violence are incredibly important. But we were able to refer to these statistics and redirect their attention and kind of reframe, because typically when someone starts bringing up homicide and they start talking about gang violence or Black on Black crime, what they're doing is trying to detract attention from guns, which are the problem, and the lack of regulation of them, and the lack of a public health approach, and the lack of acknowledgement of structural racism and structural inequity in our country, and try to kind of frame it in a way that suggests these are communities creating their own problems, and that's not the same, and we can't talk about that. And so we were able to kind of bring up this data very easily and reframe that conversation. And I can tell you that no one in that room had any idea of the role that guns are playing in domestic violence incidents and how many young children are dying that ways. So kind of knowing the epidemiology is really helpful. Which, by the way, is not to say that older youth dying in inner city and urban related incidents of violence is not. Those lives are just as important, and understanding the drivers of that is just as important, but they're different. And the way those conversations get framed often lead to either kind of polarizing conversations that don't go anywhere or productive, meaningful progress. And it's really, again, it's understanding the complexity of all of that. So this is just, these next few slides are from a paper by Dr. Annie Andrews. The QR code will take you to that paper. It was published in Pediatrics in March of 2022, and it's just a really comprehensive overview of a lot of this epidemiology. It's based on CDC data through 2019, which was the latest available at that time. As I said, we now have the 2020 data, but this is looking at pediatric gun violence all intent as compared to motor vehicle collision. So hopefully what you can see is very similar to that figure I showed you before. So green here is all, blue is motor vehicle collision, green is all intent, orange is homicide, gray is suicide, and yellow is unintentional. And now we're just going to go through that data in a little more detail in a couple different ways. So as you can see, the kind of proportion of pediatric gun deaths as a percentage, varies based on age. So in our younger children, this is largely unintentional and homicide. In the older or this sort of, early school age children, it's the same, although the proportion of unintentional shootings goes down a little bit. And there's, hopefully everyone can see that very thin sliver. There's 1% of children aged 5 to 9 who are dying as a result of guns or dying as a result of suicide. So even in this very, very young age group, that number is not zero. And then you can see suicide becomes a huge player in our 10 to 14 and 15 to 19-year-olds. But again, as you see, homicide is the number one across all those age groups. I want you to think a little bit about what we think about when we hear homicide and what kinds of pictures that brings to our mind, and what kind of biases, again, depending on the audience we're talking to, that may bring along with it. So this very busy slide is just looking at that data broken down in different ways. So again, by racial and ethnic breakdown, I should say. So on the top left, you have all gun violence in children by all intents, broken down by race and ethnicity. And orange is our Black and African American youth, and you can see that that's much, much higher. The next highest is American Indian and Alaska Native in the yellow, and I'll talk a little more about that later, particularly for this audience. And then below that, you see Hispanic, white, and Asian and Pacific Islander youth. For the remainder of these figures, the yellow and red bars drop out, and that's because the overall number is low enough that they weren't able to perform the same statistical analysis looking at this data set this way. But there is data, and some newer data, that has some pretty sobering trends for us to examine with our American Indian, Alaska Native youth, as well as our Asian Pacific Island youth, and I will get to that. The next one is looking at homicide, and again, huge gulf between our Black and our Hispanic youth, which are the next highest population. Bottom left is suicide, and again, that is more disproportionately white than the other two ethnicities, so a bit of a flip of that ethnic disparity. And then the bottom right is our unintentional shootings, where again, you see the Black and African American children are disproportionately affected. And so I had included this quote, which was from Dr. Andrews' paper, because this was the first time I felt reading a paper that was very focused on the science and the epidemiology that, on this topic, that someone really kind of acknowledged, that what's really driving these disparities, and really in a way that feels like a call to action. So Black youth carry a disproportionate burden of overall firearm deaths and firearm homicide deaths. There are widening racial inequities in all intent, homicide, and unintentional mortality rates, with rates among Black youth increasing at a faster rate than among white youth since 2013. So this is not a new problem. There is no plausible biological explanation for these inequities. Centuries of racist policies have led to a multitude of racial inequities in child health, and firearm violence is a significant contributor. Any solutions to reduce youth firearm mortality must take this into account, as any increase in youth firearm mortality will only contribute to further racial health inequities among youth in the United States. And I would say the same is true for any of the racial and ethnic disparities, which I will talk about in a little bit, but we cannot address this if we don't understand what causes it, which is why I always take a deep breath when someone starts asking me about gang violence and homicide, because in my experience, that's kind of like where the conversation goes when you start talking about gun control instead of gun safety. You have to kind of take a deep breath, take a pause, back up, and talk about the drivers. But we can't ignore structural inequity and structural racism if we're going to confront this. I will, however, today talk about things that are a little more immediate and accessible to a lot of us in our kind of daily careers that might feel less overwhelming, but it's important to be aware of this at the individual and the systemic level. So I said I was going to talk a lot about suicide today, and I am. And this, I'm probably preaching to the choir here, but if not, so the connection between guns and mental health is suicide. That is it. That is not to say that there have not been mass shooters who have been in crisis, who have had mental health issues, who should not have had access to guns. That comes up every single time there's a mass shooting. That is absolutely true. And this gets to why a lot of, pretty much all gun violence prevention advocates want, patients who are in crisis to not have access to guns. But in terms of looking at this epidemiologically, people with mental health diagnoses are far more likely to be victims of gun violence than perpetrators of it. And suicide, which a lot of people think mass shootings are a form of public suicide, as the shooter often kills themselves at the end of the incident. Suicide is this connection. Suicide is where we need to talk about if we want an epidemiologically sound solution to addressing gun violence as it pertains to mental health. And no one in the gun violence advocacy space is opposed to any and all efforts to address mental health, both at the adult and pediatric level. Our country is in crisis about this. We need more resources. On a personal note, I can't even find my daughter a therapist, and I'm a pediatrician who's pretty well connected. So we all agree we need more resources at every level, but if we address mental health without addressing guns, we're not going to be addressing gun violence. So suicide is the third leading cause of death for young Americans. You can see that depicted here. Again, this graphic does use the term accident, which sometimes is more accessible to the public, and this graphic is an every-time graphic and so intended for public kind of use. So I think that's probably why they chose the term accident there. This is looking at young people aged 10 to 14 in the year 2020, and I'll show you in a minute why that age group is being focused on. This is just another every-time graphic depicting the suicide as compared to homicide rate for young people in our country over the past now a little over 20 years. And you can see back in 2010, suicide overtook homicide, and that trend was reversed in 2020. It's a very, very alarming trend for the homicide rate. And again, some of that is predating COVID, so we're quite concerned, but suicide is a huge problem in young people in this country. And historically, I think we've thought about it more as a problem with older people. And this is why we're talking so much about 10 to 14-year-olds. So 10, I have as of next Monday, 10-year-old. So this is, and who I can't find a therapist for. So this is top of mind for me. 10 to 14-year-olds have the fastest growing rate of firearm suicide of any age group. That's birth to death over the last decade. You think about a lot of suicide prevention and awareness campaigns and how they have often targeted older white Americans, which, historically is a very evidence-based approach, and veterans and other groups that we know are high risk. And then think of how often someone talks about suicide awareness in the context of children, which is increasingly often, especially in the last couple of years. But how often do they, when they're talking to you about suicide awareness, do they talk about access to guns? We have to talk about this. This is terrifying. And so I said I would get a little bit back into some of the racial and ethnic data that may be more relevant for this group. So this data is from an Every Town for Gun Safety report, the rise of firearm suicide among young Americans. If you scan that QR code, it will take you to it. Anna had mentioned there may be some Moms Submit Action folks in the audience. I don't know if anyone's here today, but if you are, big shout out. I mentioned a lot of my own work has been within the sort of nonprofit, nonpartisan gun violence prevention, non-healthcare sector. And a lot of it is because of feeling like healthcare was not doing enough about this. But Every Town, which is the kind of policy and research overarching body under which Moms Submit Action falls, has been churning out really excellent research for many years, and is also like a clearinghouse for all the research everyone else, including all of us, are doing. And they put it together in this digestible way with these beautiful infographics that are easily understandable and meant to be shared and look pretty in PowerPoints and on social media. And so that's why I have a lot of those here. So this is based on, all of this is based on CDC data, the same data sets I was quoting earlier, but this now includes 2020. And so even though the total number of American Indian and Alaska Native children who die as a result of firearm suicide is much lower than the total number of Black or white or Latino or Latina children, it is 4 times higher. The rate per capita is 4 times higher. And I find that really scary. And I think it's really important when we talk about data that we understand our local data or our population specific data, because that's, how we're going to have the most change. So I think there's a lot more that needs to be done to explore that. And then when we think of how we take data and we use it to inform advocacy work, kind of understanding how maybe the conversations that we have with those populations may look different, or is it that there is targeted messaging to those populations? I think you all are much more the experts of that than I am, but that's really scary to me. Similarly, Asians and Pacific Islanders, who have the lowest rate per capita, have by far the fastest growing rate. So that bar on the top left, it might look very different in a couple of years because the rate of change over time is skyrocketing in this population. And again, I don't think we understand why. I know in my home state of California, which has a very high Asian Pacific Islander population, we've also seen, even in progressive California, we've seen a rise in hate crimes against this population and several high-profile mass shootings. And that's being seen across the country. And, how is that impacting folks and their sense of hopelessness and growing up in a culture that doesn't seem to value them? And is that related? I certainly don't think we understand that yet, but those two trends really scare me. So when we look at numbers overall, we also have to look at the breakdown. And then similarly, I do a lot of work in the LGBTQ youth advocacy space, both with respect to gun violence and just more globally. And there's huge disparities here. And I know I'm probably going to run out of time, so I'm not going to, I can spend 20 minutes on this slide alone, but just knowing that our LGBT youth are at extremely high risk of firearm suicide, of suicide overall, which is what this slide is depicting. It's from the Trevor Project, which that QR code will take you to. But then when we think of, so children who are at high risk of suicide, guns are the most common fatal means by far. This is why I think it's important for us to talk about this. And even within the LGBTQ sort of umbrella population, it's really our trans youth that are driving that. So 1 in 5 trans and non-binary youth in the past year have attempted suicide, compared to 1 in 10 cis, LG, or B youth. So in other words, trans youth are twice as likely as their lesbian, gay, or bisexual peers of attempting suicide, and lesbian, gay, and bisexual children are much more likely than heterosexual children of attempting suicide. So this is a house on fire level problem. Nearly half have contemplated, and 1 in 5 have attempted. And then when you look at the racial and ethnic breakdown within that overall 14%, you see, so 12% of white youth of this population have attempted suicide, as compared to 21% of our Native and Indigenous youth. I am not the expert on intersectionality, but I've certainly learned a lot more about it in the last few years. And when you think of any one minoritized or marginalized identity, and how you start adding or stacking different identities together, the intersection of those isn't just additive. It's very complex and nuanced. But being a gay or trans Indigenous youth as compared to a cisgender heterosexual white youth, your risk of firearm suicide completion in this country is astronomically higher. And that was really the point I wanted to make here. And as I've been kind of skipping over this, just to put things all together into numbers, suicide is about 1/3 of all pediatric gun death. It is a higher proportion of our 10 and up. And guns are by far the most common fatal mechanism. So guns are fatal 90+% of the time. So 9 out of 10 children who attempt suicide with a gun will die. Whereas pills, which I see on a nearly daily basis in my inpatient practice, are fatal anywhere from probably as low as 2 to about 5 or 6% of the time, which if, for those of us who have taken care of children who have used pills as a means of attempting to end their life probably kind of jives with our personal experience. And so this gets to the means and why they matter. And I see I had my 90% statistic on this slide. I should have just waited. So when we talk, and this is my biggest critique of the House of pediatrics specifically, we're getting much better at talking about suicide and the fact that it's a huge concern and there's a mental health crisis. And we'll even say things like lethal means. But I encourage all of you to conduct a straw poll of your friends, especially if they're non-medical, and what they really like, what they think lethal means. I did this with some of my friends who are medical, and they were like, well, pills are fatal. And I said, yeah, 2 to 4% of the time. So if you get to talk to somebody about one thing, do you want to spend more time talking about pills, or do you want to spend more time talking about asphyxiation and guns, which are the number 2 and 1 fatal means for suicide? So how we attempt suicide really matters. And so Harvard School of Public Health has this great campaign called Means Matter. And that's really all this slide is meant to call our attention to, is if you want some resources and kind of how to have the conversation, it's a great place to go. But it's very important to talk about so yes, lethal means counseling is really, really important. And lethal means counseling as a category means anything that could be lethal, but the focus is really on guns and asphyxiation. And from a kind of mitigation strategy standpoint, it's easier to conceive of gun mitigation strategies versus asphyxiation mitigation strategies. It's harder to remove absolutely everything that could conceivably be used as a noose, whereas it is fairly straightforward to restrict a child's access to a firearm. And that's why we need to talk about it. And we need to say the word gun. If you're having a patient-facing conversation, you need to use the least confusing word, which is gun, not firearm. If you're kind of talking to another group of physicians, firearm is sort of the like medically accepted sort of sciencey sounding word. And people have actually even studied this question. And if you're talking to stakeholders and you're trying to avoid rocking the boat, then that's a great time to say that you want, support for a lethal means counseling project. But when you're sitting there with a family in front of you, be it parent or child, you need to use the word gun so they understand what you're meaning. So talking about screening and secure storage. This here is to draw our attention to the kind of evolving discourse within for many of us, home academy, the AAP over the last decade. So we've been talking about this for a long time. Our first really robust policy statement on this came out in 2012. It said a lot of great stuff, but one of the things that it said, I highlighted here, nevertheless, the safest home for a child or adolescent is one without firearms. Lots of other really meaningful things that I've used a lot in my own career were in that document, but that was kind of the takeaway, I think, for a lot of people, both in the lay public and in the healthcare space. And when you think of the number of gag laws over the last decade, am I saying the AAP caused any of that? Absolutely not. But do I think the public perception that if a doctor's asking about guns, it's to judge you and potentially suggest that you get rid of them might have been out there? Yes, I do think that was out there. And so then flash forward to 2012, the Council on Violence, Injury, and Poisoning Prevention came out with this. It's not really updated, it's like foundationally revised policy statement, and it's even there in the title. So firearm related injuries and deaths in children and youth, injury prevention and harm reduction. I was really fortunate to work with someone early in my career doing addiction work who introduced me to the concept of harm reduction, which is really like, don't let perfection be the enemy of good enough. And I think medicine is often very guilty of that. And it's really kind of profoundly impacted my own career. And I'm so grateful to see us starting to recognize that. Sometimes we focus so much on the gold standard that we miss that we're not going to get there. So how do we meet the patient or the family where they're at? So this section is my favorite part of that document. So as motor vehicle injury prevention is focused on harm reduction by increasing the safety of the vehicle environment and decreasing user risk and not removal of vehicles from the road, a similar strategy must be considered for firearm injury prevention. So we're saying we gotta make it really clear to people, we're not talking about taking away guns because that's a personal choice and we don't have any role in that. We're talking about how to keep people and specifically children safe and to partner with them and to understand their unique circumstances. And that's where we need to go. That's where we need to be doing this work. And so with that in mind, this is a really fantastic resource for anyone who may not be familiar with it. If you're an AAP member, you can Google this or go to that QR code. It'll take you to it in PediaLink. It's free if you're an AAP member. And it's really just a safe storage curriculum intended for pediatric healthcare providers. It's based upon the principles of harm reduction. So safest is locked unloaded weapon that is separate from the also locked up ammunition. And then you, for example, have a family that has a personal firearm for protection that they're keeping in their bedside table or under their bed. You will not get that person to safest, but you might get them to safer, which could be, for example, a biometric gun safe that they can quickly, access, that they may keep the firearm loaded in. Or you may get them to safe, which is a cable safety lock. So, do you want to be so focused on, the safest that their takeaway is kind of like, oh, my doctor doesn't understand me, and this is not a person I can talk to about this. Or do we want to, we want to be okay with safer or safe, because it's definitely, anything is better than sitting in the bedside table or under the bed or on the top shelf of the closet. So this is a great resource. There's really quick modules, which are listed on the slide there. And then there's some videos that show kind of how to have these conversations with different ages of child. So obviously with a young child, you're having a conversation with the parent, but with adolescents in different contexts, like a mental health visit versus not. Different sort of racial and ethnic concordance versus discordance of the provider and the parent. And then there's some CME type questions, so you can get CME credit. It's a really good resource. And then this is my favorite resource for talking about secure storage to families. And it feels like the AAP came up with it, but it actually came out of Moms Demand Action. It is our public health facing campaign around safe storage for families and really anyone who interacts with children. And it was designed as kind of like a train the trainer. So there's a training that I went through many years ago to be able to give this presentation to people in the public, but you can also train other people to be SMART ambassadors. And SMART is an acronym. And that QR code will take you to their website. There are so many, every single time I look at this website, there's more resources than the last time. Printables, infographics for social media, examples of scripted conversations to have with families or to have with peers, things of information about secure storage devices, things in English and Spanish. This really fantastic video that has multiple different stakeholders talking about the importance of secure storage, including a retired police chief and a avid gun owner and a mom whose child died as a result of an unintentional shooting. I cannot say enough wonderful things about Be Smart. If you remember no other websites from this talk today, it's besmartforkids.org. Wonderful, wonderful resource. So I just included a couple of our infographics that we use on that website here for your kind of viewing. So again, we say about 4.6 US children live in a home with an unsecured loaded gun, and that was pre-pandemic numbers. So that was based on a national survey, and that hasn't been redone, so we don't know, but it's almost certainly much higher than that actually at this point. And 3 out of 4 school shooters acquire their firearm from the home of their parent or a close relative. Those numbers are almost identical they're actually even higher for pediatric suicide. It's almost always a gun from the home. So that is why secure storage is an effective mechanism, not just for unintentional shootings, but also for homicide and suicide, because when it's children who are the shooter, they're almost always getting the gun from the home. So one more time, if children are the ones doing the shooting, whether it's intentional in the case of homicide or suicide, or unintentional in the case of like the toddler type shooting, they're almost always getting that gun from the home. So secure storage addresses all intent types of pediatric firearms injury and death. And then this is just a couple examples of how to do the A component of Be Smart, which is ask about the presence of guns in the places where your children stay and play. So whatever your storage practices in your own home may be, if you own a firearm, you don't know that about the other environments your children spend time in. And this one also isn't really talked about enough. So on the left, you have Be Smart's way of kind of suggesting having that conversation over text. And on the right, you have the AAP. This is from healthychildren.org. And you can see that those are virtually identical. So there was an AAP pediatrician who worked very closely in the development of the Be Smart information. AAP has its own campaign called Asking Saves Kids. They're virtually identical, and all of us want this information to be shared. That's the kind of takeaway. I'm going to blow through this really quickly. This was, again, more to convince my hospitalist colleagues recently that hospitalists care about this. But this is the result of a randomized control trial that a friend of mine did at Montefiore in the Bronx, looking at how using a safe storage intervention to provide counseling in hospitalized children, how that would be perceived and lead to changes in outcomes. And they used Be Smart as their intervention. Basically, what they found is a really high prevalence of exposure to gun violence in this population in the Bronx. Parents who received the Be Smart kind of intervention had a significant improvement in their knowledge around gun safety, and an increased willingness to ask about. So at the point of discharge, they had an increased intention to ask about the presence of guns in other homes. And then when they did 1 month follow-up, that was sort of corroborated in that they were asking about guns in other homes. So this was really cool. Also, just to have a prospective randomized control trial of anything in pediatrics, you probably all know, is really rare. So for us in the gun violence prevention world, this was very exciting. And this was a sub-analysis of some of the work where they surveyed parents around their beliefs and attitudes. And what they found is 76% agreed pediatricians should talk to parents about safe storage. However, only 9% reported that actually happening. So they were very open to it, but it wasn't really happening. So I view that as a solvable problem, right? And this is not nobody's gonna like do that's not going to be on like MSNBC, right? It's not a sexy enough headline, but like really parents are willing to talk about it and we don't do it. We can fix that. We can get to ways to support, whether it's streamlining efficiency so there's more time, or giving people resources, which is part of what today is about in that safer curriculum. But it's not that there's resistance by and large, and that's been done in lots of different populations. Medical University of South Carolina did that study. So in the South, a very different demographic than the Bronx. Majority, it's always north of 65% in every study I've ever seen looking at parental perceptions. They're willing to talk about it, but then it's south of 10% that it actually happened. The other thing that gets brought up in the adult literature is not so much an unwillingness to talk about it sometimes, like a sense that it's not relevant, but even more so, a kind of feeling of my doctor doesn't know what they're talking about. And this gets to a lot of us aren't really familiar with these devices. I think all of you or many of you are, because I think the demographics of where you live and practice are quite different than, urban California, for example. So this may be really irrelevant here, but if the issue is we're not familiar enough with devices, if we're just still saying the thing we learned in residency, which is go buy a big gun safe and then a separate safe for your ammunition. Yeah, we definitely can supplement our knowledge. And so these are some resources from Be Smart, but there's the National Shooting Safety Foundation has great resources. Project Child Safe there's so many places you can go. You could literally just Google like gun safe or secure gun storage device infographic and find tons of things out there. I happen to like these because they provide cost estimates and examples of like what they do versus do not do. So moving a little bit into safety laws, we won't have nearly enough time to talk about this. But if you want to understand more about the kind of history of gun safety legislation in this country, this is a great resource. It's very dense. So I suggest it's free online. You could actually purchase this 300 and something page book from the RAND Corporation. But like I said, it's free online. And you can kind of search specific topics within it. But the RAND Corporation has done the most comprehensive overview of gun policy in the United States. And they've gone through this 3 times. The most recent one, we're very fortunate, was just last year. And they look at the way that they look at it is from the legislation and then outcome, and seeing kind of whether the legislation has the intended effect or not, going back into the 1970s, and then looking at all the papers published since the 1990s. Again, keeping in mind that there was a congressional gag order in place for about 20 years. And so there's the one caveat I would say to interpreting this policy has this effect is recognizing the absolute dearth of research relative to other causes of death. So we don't know for certain that something, some of the things that look like they work, but we don't have like super, super robust evidence. That's likely because not enough research has been done, which is why we need to continue to do that. But this is a really fantastic resource. And so this, actually, if you go to their website, which is on the slide here, this is actually a much more comprehensive interactive graphic here. But just in the interest of time, what you have on the left is gun policy, and what you have on the right is outcome. And so brown may or does decrease gun violence. And then it's broken down by categories there. So you can see violent crime, unintentional injuries and deaths, suicide, mass shootings. And then green is may or does increase. I want to call everyone's attention to the fact that concealed carry laws and stand your ground laws, which often are sort of brought up by a certain sort of in opposition to all these other gun policies that are discussed. They're sort of brought up as something that might increase safety. And what we find that I think is probably not surprising to many of us, just from an epidemiology standpoint, is concealed carry and stand your ground, which sort of support increased presence of guns in public spaces or in things, like conflict type situations, lead to an increase in gun violence. And again, I think that is not surprising, but also an area that needs to be further researched. And there are a number of states in the country that have those laws. But really for us here in pediatrics, background checks, prohibitions associated with less mental illness, because our underage population can't purchase weapons by and large, but prohibitions associated with domestic violence and child access prevention laws are what I wanted to draw everyone's attention to. So all of those do work. We know that they work. We know that in states that have more robust versions of those laws, or that they were passed a longer time ago, we have more data, and we see even more data that those work. My state of California has data on all of these laws. So and when we think again about children, so background check means that the adult in that child's life, if they don't meet criteria to be, if they're likely to not be a lawful firearm owner, if they wouldn't pass a background check, then you can imagine how not having a gun in the home of that child as a result of it may not be appropriate for that adult would lead to a decrease. And then again, I kind of harped on the domestic violence connection, so that should make sense. And then those child access prevention laws vary by state. There are different versions thereof, but it's about making sure that there are protections in place to prevent children from accessing firearms in their homes. So those work, and we need more research. This is a really great resource for anyone familiar with Everytown. They do this gun law ranking. The point isn't to get into a competition, but it's to look how your state, what laws your state has, which you can do independent of doing a comparison like I've shown on the screen here. But if you want to do a comparison, I just put California and Alaska because of my practice environment and where you are. And again, the point not to be a competition, but California really has put a lot of legislative energy and attention into gun safety laws. And you can see, so blue is the strength of those, and red on the bottom is our gun violence rate per capita. Our gun violence rate per capita is much lower than it is in Alaska, which is comparatively among the weaker gun laws in the country. And I'm not the expert on that, but I just wanted to include this sample. So if you do go to that website, you can choose Alaska, and then it will go walk you through all of these different categories of gun safety law. It will show you details about what those laws do and what the intent of them are, and you can see whether your state does or doesn't. So I put this screen up, again, pretend the blue, which is California, is not there. I was really more focused on the right-hand side, which is Alaska. So you do not have a background check law. You do not require a permit for concealed carry, which I know we're all not sure what's going to happen with that as a result of the Supreme Court decision in New York last year. You don't have an extreme risk or a red flag law. You don't have a no shoot first law, and you don't have a child access prevention law. And so if anyone here on this talk is doing this work, that's wonderful. If you're inspired and want to get more involved in this advocacy, it sounds like you have an active Moms Demand Action chapter. I imagine they're doing this work. And these are some of our highest priority laws that we focus on trying to be sort of strengthened in states that have them and passed in states that don't. And then with like a minute left, so how do we take all of this and then what do we actually do? And I bet most of you are already doing this. So, I mean, I think the biggest thing that you can immediately start doing if you're not, or if you are and you're not sure if it's impactful, is screen all patients and families for access. And then whenever we screen in healthcare, we have to provide a resource, right? We can't just find out somebody screens positive and then not do anything. So hopefully some of these resources I gave you today around secure storage and devices might be helpful. You probably could all teach me, but screen and then provide secure storage counseling. Don't assume that we know, maybe the case in your practice environment, you assume the answer is yes. If some people have taken that approach. Just assume the answer is yes, and then skip to the secure storage counseling. It might save time, so that's an option, but don't assume it's a no without asking, I guess is what that should say. Kind of familiarize yourself with the basics of devices, and if you can provide those, so law enforcement, municipalities can do this. Oftentimes Moms Demand Action actually can help you with that. Probably Child Safe can help you with that. There's lots of resources to get devices. Really, again, we should screen everyone, but we should be potentially, especially attentive to our adolescents. And to that, when we're kind of thinking about domestic violence and risk of that, are we asking about firearms in those homes? And with all of this, these are sensitive topics. There's always going to be the chance that folks don't want to tell us, which is why just screening isn't enough. And you really, even if you do screen universally, you should focus more of your energy on the secure storage counseling than the screening, because that's the impactful intervention. But not being afraid, not getting into this absolutism, perfection being the enemy of good enough, I think is really, really important. In our institutions and communities, I think engaging in this work, partnering with other people that are doing this work, especially getting out of our healthcare silos, and finding out who is doing this work in our community, and because they're going to be the ones that know what works in your local milieu, and they've probably already thought about all of these things. And then having a healthcare voice to kind of support the work that they're doing to legitimize that can be really helpful. Knowing your electeds, understanding their priorities, finding some common ground is so important. And I think, there's resources to help with that. And then similarly at the state and federal level, again, kind of know who your resources are. The AAP can obviously help a lot with that. I imagine Dr. Ogina can. She knows everyone. Signing up for ledge alerts, and then trying to visit people, again, I know the geographic considerations of Alaska are very different than California, but, knowing who your person is and what's important to them and to their constituents, and finding out how you can talk in language that's similar is really key. And then, so just in conclusion, this is a really complex problem that needs complex solutions. And so even within that, we can't let perfection be the enemy of good enough. Find the part that's appealing to you, or that seems doable and feasible, and start chipping away there. And never conflate politics with policy. And I know I've made a couple of jokes about my living in California. I think people have perceptions about all kinds of places, but states are not blue and red. They're full of people that have differing viewpoints. And then the way that gets filtered up into sort of perceptions around voting and how the media covers things further polarizes stuff. But my area of California is very, very conservative. There's a very prevalent gun ownership, and the reasons for gun ownership are very different than in the more urban parts of the state. I'm in the Central Valley, and I've been having these conversations with families for 11 years, and really approaching it from this, like, I am your partner, how can I help you? I am not judging you lens. Like, I can honestly say people do not get defensive when I talk to them about this. So I think, it's really important to understand the distinction there, and policy and legislative advocacy is crucially important, because policy affects all of us. Policy is bigger than politics. And when we're talking about policy, it's because we care about the outcomes, and not what color and what box somebody checks on a ballot. And especially you have to reach across the aisle, because, in any sort of kind of divided approach to this will not be successful. So I think we're at time. If folks want to scan this QR code, it's asking you to kind of think about an individual change that you could make to promote gun safety, or you could also use that to comment on something you're doing. I think knowing what people are doing is really important as well. So that will take you to a Google form if you want me to follow up with you in a few months. As an accountability partner, then you can give me your email address and I will. And if not, that's okay too. And I think I'll give folks a second to scan that if they would like. I see someone saying Alaska Moms Red Locks to Clinics, which is wonderful. I love that your chapter website has a tab dedicated to Be Smart. You guys could teach my chapter. This is really exciting to see. And I'm hearing that there's some bills being introduced, which is also wonderful. So partnering with moms and any other groups to kind of support your legislature making the right choice about those would be a really great thing to do. I'm going to stop share. just say thank you to all of you, and for the extra 4 minutes of your time that I took.
Yeah, thank you so much, Dr. Webb. That was chock full of information. I mean, a lot of kind of sobering and disheartening statistics, in the beginning, but I do love all the QR codes. That's kind of a new trick for all the, deeper dive into the articles, the data, and resources, really. There's a lot of resources in your presentation, and we thank you for some tips and providing a framework of how we can partner with other coalitions and with to help advocate for common sense things like storing your guns safely and securely. And our Moms Demand Action Alaska chapter is willing to provide us trigger locks for free to give to clinics. So let us know if your clinics would like some of these. And then they have a bunch of rack cards for the Be Smart too that they can provide to clinics as well. And like I said, we're nowhere near where California is in terms of kind of legislation. But we are obviously probably on the other end of the spectrum in terms of gun ownership. We have a lot of it's a different environment, and it's a work in progress for sure. I think there are many opportunities for improvement of how we can bring it up and our anticipatory guidance like we do a multitude of other things, but it's something that we don't necessarily bring up first in our conversations with families. And I think it's something that we just have to practice and get better at, because it's really the fact that gun violence has overtaken motor vehicle accidents is just like, wow, I can't believe that just did that. But like I said, there is a lot of information that you provided. We will share this with our chapter members on our website. And Dale, did you put in the link for the CME into the chat box? I think you did.
Yes,
Hopefully.
it's in the chat box.
So,
I
okay.
apologize, I unshared, but I just because I hit a million different resources, the QR code on the right here is actually just like a repository of all of those. So if somebody had vertigo from all the individual QR codes, if you just scan that one, it will give you a Google Drive that has every single article, but then probably even more useful, like those different websites and reports and infographics and links to them, not the individual infographics, or it'd be 1 billion pages long. So that I think is going to be that's in the presentation also. So when
that's awesome. That is like the one-stop shop QR code right there, people. So we'll leave that on for you to click onto, and then we have your contact information there. Thank you for sharing. And again, thank you for your time today. And I'll see you at the next conference.
I hope so. Thank you for doing the work that you all do on this and every other topic. I think to do this work in such a geographically disparate state is so much more challenging. And obviously, Dr. Agina, you're amazing, but for everybody else, really hats off. I think sometimes getting started is so much harder when you don't necessarily have the 50 people that you can talk to. It seems like you're the one-stop shop for everybody, but just such important work, and understanding how one community is different from the next is really, really important in that too.
Yes, thanks again. This could be an entire workshop or afternoon session or in a conference, but again, a lot of information that 1 hour. And again, we really thank you for your time today. Thanks everybody, and thanks for staying a little bit extra.